Inno- inno- inno-
Session with the guest. I hand over the session to Dr. Sanjay Kara. Sir, the session is yours. I hand over to you. I just take a few seconds to introduce Dr. Sanjay Kara because the slides have just come because he doesn't know any and requires any introduction, but he is a senior consultant in Bharati Hospital and is a past president of Endocrine Society of India. He's a board member and chairperson of Education Working Group, International Society of Endocrinology. He's a president of Indian Professional Association of Transgender Health. This is IPAT. Section editor of Endocrinology API Books of Medicine. Section editor of Tropical Endocrinology Endotext, the PubMed Index textbook. His hobbies are traditional Haryanvi Mudgar and the Bhangra. Dr. Sanjay Kala is an endocrinologist, DM endocrinologist from All India Institute of Medical Science, which is a prestigious institute from New Delhi, and is a president-elect of South Asian Federation of India. Welcome, Dr. Sanjay Kala, sir, and the handover session to you.
Thank you, Mr. Basu, and greetings to everybody who is gathered with us today. Today is a special day, and it's a blue day in our calendar. And you must have seen the blue color of the video, the blue color of one of our favorite beverages, and the blue color that all of us are sporting today, because blue is the color of diabetes care. And today is World Diabetes Day. If it's World Diabetes Day, it makes sense for us to have a world-renowned expert, an expert who has actually influenced the way diabetes is treated in the world. And if insulin is 100 years old, our expert today, Dr. Om Ganda sir, is someone who has more than a half century of experience to back his experience and expertise also that he brings with him to the table. Warm welcome, sir. Dr. Om is a graduate from the prestigious SMS Medical College at Jaipur and an MD Medicine from AIIMS New Delhi. So, हमारे ही लड़के हैं, हमारे छोरे हैं. Warm welcome again, sir. And he has tenured at the Joslin Diabetes Center, the Harvard Medical School as research fellows, and he is currently director of the Lipid Center and the chair of the Joslin Clinical Guidelines Committee. He is also an associate professor of medicine at the Harvard Medical College in Boston. He has been co-investigator in the leading trials, the trials which have actually taught us how to manage type 1 diabetes and which have taught us how to prevent diabetes. Nearly 200 peer-reviewed publications, book chapters, original publications. He has served as a member of board of directors of ACE and also the Lipid Guidelines Task Force. And he's a frequently invited speaker across all continents in the world. Once again, Dr. Ganda, warm welcome.
Thank you so much, Dr. Kalra, for that very kind introduction. It's a pleasure to be here, and thank you all for joining this evening at this late hour. But we thought we'll together, Dr. Kalra and I will put together this program where we talk about some of the recent advances and some unresolved issues regarding a very common problem of dyslipidemia and diabetes. Let me share my screen and begin with the first slide. Can you see my slide?
Yep, perfect. We need to switch to maybe
Great.
Screen mode. Yes, now it's perfect.
Okay, great. Let me just, okay. So as I mentioned, diabetes is really something that has been recognized by all of you as a major risk factor for dyslipidemia and cardiovascular disease. And as Dr. Kalra mentioned, today is the World Diabetes Day, and I dedicate this lecture to all people with diabetes and all people who are taking care of people with diabetes. It was exactly a year ago that I spoke at this meeting. And today I thought I will bring you up to date on some of the lipid issues. These are my disclosures. Let me see if I can move this bar. And I have quite a bit of area to cover. My main learning objectives are impact of diabetes on atherosclerotic cardiovascular disease events, current approach to manage LDL cholesterol very briefly, and what is the role of LDL cholesterol throughout the lifespan in risk reduction. I'll mention novel and upcoming treatment options to achieve LDL cholesterol goals, and I'll bring you up to date on rationale to manage dyslipidemia beyond LDL cholesterol and current evidence-based options, including some of the very recently completed studies. So I don't think I need to remind any one of us here that cardiovascular disease mortality is increased by multifold in people with diabetes. Let me see. So shown on the left here is a very large analysis of 37,000 people with type 1 diabetes, mean follow-up 11 plus years. Shown here is the incidence rate of cardiovascular mortality. You can see it's about 3 to 4-fold greater. A lot of time people think that patients with type 1 diabetes don't have much cardiovascular disease. They have mostly microvascular disease, but that's not true because cardiovascular disease is very prevalent compared to very low incidence in non-diabetic controls. Same exists for type 2 diabetes. This has been better appreciated for a long time, that type 2 diabetes also increases the risk by more than 2-fold, even though overall the mortality has been going down with all the new treatments and ways to manage the problem. But the residual risk remains very high in people with both type 2 and type 1 diabetes. Now, since we're talking to your patients about cardiovascular disease in India, this is the most recent analysis published last year of incidence of ASCVD in South Asians versus Europeans. Some of you may have been aware of this data. This is a very large analysis, about 450,000 Europeans in UK and 8,000 South Asians. They looked at major cardiovascular 3-point MACE, MI, revascularization or ischemic stroke, and not cardiovascular death, but coronary revascularization. Mean age was 57, median follow-up was 11 years in this particular analysis. And if you look at this on the right side, it's very clear that in countries like UK as elsewhere, the cumulative incidence of cardiovascular events is much higher than it is in Europeans. This has been appreciated now for some time, starting with the Inter-Heart study in India and other studies. And it just shows that overall the hazard ratio for South Asians, no matter where they are, is at least twofold. And it occurs at younger age, highly significant. Adjusted hazard ratio, after you adjust for all the other covariates, is still very highly significant. And the 3 major determinants of the 11 they looked at included diabetes, hypertension, and central obesity, each of which is more common in South Asians. Okay, so what about this beautiful particle called LDL cholesterol? After all these years, since 1994, when the first clinical trial for cardiovascular risk reduction with statins was published with simvastatin, 1994, you can see that we have now had ample evidence that even though it's a beautiful particle, it's the cholesterol part of this particle, LDL cholesterol, which is associated with atherogenesis. So whether you look at observational epidemiological studies or genetic randomization studies with Mendelian analysis, randomized control trials, most importantly in humans and animal experiments, LDL cholesterol is the most causal and most important target to improve cardiovascular outcomes. Now, we all know that there are 27 different RCTs that have been completed since 1994. Okay, so we have done a lot of work globally in looking at these 170,000 people in these 27 control trials, which proves that every 38 milligram percent reduction or 1 millimole reduction in cholesterol, okay, leads to about 20 to 22% reduction in cardiovascular outcomes. So if you lower somebody's LDL cholesterol by about, let's say, 40 milligram percent from baseline, you reduce the risk by 22%. If you lower it even further, you reduce the risk further. And there doesn't seem to be any point of inflection. The question is it safe and can it be achieved? And the answer to both questions right now appear to be yes, although I'll show you some highlights about certain age groups. Okay, not only that, but statins are the only drug that reduce cardiovascular mortality by 20% and total mortality by 10%, not possible by any other lipid-lowering drug. Okay, in spite of all that great information, a lot of knowledge, here is the NHANES data in US in primary prevention. In 6,600 people published last year in New England Journal, that if you look at even the minimal goal of LDL cholesterol less than 100, only about 60% or so people are getting that target, in spite of all this knowledge. And this is primary prevention with LDL less than 100. Correspondingly, non-HDL less than 130, or 55% of people. So we're not done as well as we should, because there are a lot of people who walk around with very high LDL cholesterol. What about secondary prevention? And I'll show you more evidence that in secondary prevention, people with cardiovascular disease or multiple risk factors along with diabetes, the LDL less than 70, most guidelines. How are we doing? Well, here are the guidelines. So far, patients with diabetes who are age 40 to 75 years without cardiovascular disease, one must use moderately intensive statin therapy. These are the combined AHA and ADA guidelines issued last year. In patients with diabetes who are at higher risk, especially multiple risk factors, or who are above the age of 50 to 70, it is now recommended that we should start the high-intensity statin therapy if the LDL cholesterol is above 70, with the goal being to reduce it by more than 50% from baseline and less than 70. And what about people with diabetes and 10-year risk of more than 20% in primary prevention? You can calculate that with one of the risk ratios, risk calculators, in spite of its limitations. But you can consider adding ezetimibe to maximally tolerated statin therapy if you cannot achieve your LDL cholesterol goal. So talk about unresolved questions regarding drug therapy. That is the next major area that I want to consider. When is it too early to start statin? The guidelines keep saying above the age of 40, for the simple reason that all the trials were done in people above the age of 40. But we know that atherobiology begins during childhood. There is evidence that people can have atherosclerotic plaques if they have other risk factors. Second question is, can LDL cholesterol be too improving if the LDL cholesterol goes lower and lower? And we have now evidence that lower is better. Are there any guidelines, or should there be any guidelines as to what age to stop statin or what age to not start statin, and at what goals are in older people? And then finally, this vexing problem that all of us face, and more so in Indian population, but everywhere in the world, what is triglycerides, lipoproteins that we don't pay much attention to, other remnant that's from triglycerides, lipoprotein. How do triglyceride-lowering drugs work? Do they reduce cardiovascular outcomes? And the so-called fibrate dilemma. And I'll dwell on that a bit further, because in spite of more than 50, 60 years of use of niacin and fibrate to raise HDL cholesterol or to lower triglyceride, where do we stand now with such drugs? And last minute or so, I'll just mention a word about LPA. Is it ready for prime time? Something that we have known about for some time now, but we don't have any drugs to treat. Okay, So here are the additional considerations for statin use by age in most recent guidelines that were put together by the AHA in 2019, and ACC updated them subsequently. So it is well known that people who are already on statin therapy in older age groups in primary prevention, okay, without pre-existing, it is reasonable to continue. Don't stop it. The reason why it is being said now is because we have some epidemiological observational evidence that if you stop the statin, you actually get more heart attacks. I won't have time to get into that, but I'll show you some of the trials that are going on, and some of them about to be completed. Secondly, in older agents above the age of 75, it is reasonable to initiate statin therapy. Not only don't stop it if they're on it, but to initiate it after clinician-patient discussion if they happen to be at high risk. We are all living longer, which is a good thing, and we're all living healthier at older age. So why should we take the risk of further cardiovascular morbidity and mortality even above the age of 75? And finally, I think this is very important that both NIH and AHA and ACC now recommend that in younger adults, don't wait till age 40, but even in the age of 20 to 40, it is reasonable to start statin if either they have long duration of type 2 or type 1 diabetes, or they have nephropathy as indicated by persistent high albumin creatinine ratio or low GFR, or retinopathy, neuropathy, or PAD. So I think this is well appreciated now, and I get many referrals from the pediatric service even at age 18 and 19, asking when is the time to start statin if they have strong family history and any of these major risk factors. Okay, so what are these ongoing randomized control trials with statins in older adults, which I think will be an extremely important new awakening when these trials come out. First one may be coming out next year or the year after. This is a study being done in healthy people above the age of 70, 18,000 people, but without diabetes, general population. Atorvastatin 40 versus placebo, and the endpoints are overall survival or disability-free survival. Okay. Notice there is no cardiovascular endpoint, but because survival and disability becomes more important in this age group. But there is a study in France called SIGHT, which may be coming out earlier than the first one. This is a study where they stop the statin in people above the age of 75 versus a group that continues. And the endpoint is total mortality and cost effectiveness. And finally, a wonderful study started by Duke and NIH last year. Will take 5 more years to complete, at least 4 more years. These are community dwellers, 75 years or older, 20,000 people, atorva 40 or placebo. And in this group also, the endpoints are death, dementia, but also cardiovascular events. So I just want to kind of give you a heads up on what's likely to come out next time we might be talking. Okay. Now, who are the people who are at very high risk for future cardiovascular events? Okay, these are the people who especially need our attention to go to LDL cholesterol much lower than even 70 based on newer trials. Well, we all know that if you have 2 or more of these 4 cardiovascular events in the past, history of ACS, history of MI, history of stroke, or history of symptomatic peripheral arterial disease, these people are at very high risk for future events. Or you can have any one of these 4 and 2 other high-risk conditions, 2 out of the 9 that are listed here. Age above 65, history of prior cabbage, diabetes, hypertension, CKD, etc., smokers. So you can see that it doesn't take very much for you to get 2 of these high-risk conditions in people with diabetes in particular, who already have one, and either CKD, hypertension, or age above 65. With 1 prior event, they become candidates for more intensive statin therapy. Okay, so what are the guidelines in these people? Well, I think I can tell you that the AHA ACC guidelines of 2018, including ADA 2020, are up for renewal. These are already too old based on the newer studies, and NLA and Canadian guidelines all say should be less than 70 LDL and more than 50% reduction, which is the minimal requirement. Endocrine Society came out 2 years ago and said, well, now that we have evidence, make it less than 55. ACE and ACC 2022 now just recently reiterated that yes, we should go to less than 55 or non-HDL less than 85. And finally, ESC and EAS, the equivalents of AHA, pointed out even 2 years ago that we should go even lower to LDL less than 40 if the second event occurs in less than 2 years. So if someone has 2 events within 2 years, then the goal should be less than 40. There may not be enough evidence for this, but that is what many people are now trying to do. My personal goal is anybody with diabetes, with 2 or more multiple risk factors, certainly with those with prior cardiovascular events, the goal is less than 55, not less than 70. If you can safely achieve it, and if the patient has no side effects, which is now well known that the current drugs that we have minimal side effects. Okay, now that's well said and done, but what about people who do have very high LDL cholesterol who cannot get to that goal of less than 50% reduction or LDL remains above 70, or who just cannot tolerate statins? About 10 to 12% of people globally have statin intolerance, meaning that they cannot tolerate any statin beyond the minimal dose, which is not adequate. To have true statin intolerance is extremely rare, and even to have partial statin intolerance is more commonly felt by patients or physicians than is really the true, because not everyone goes ahead and tries almost all statins before quitting statin. And I would never stop a statin unless I've tried almost all of them. So in addition, of course, there are secondary reasons to consider, such as common conditions like hypothyroidism, vitamin D deficiency that can cause myalgia and make statin intolerance apparent rather than real. Drug-drug interactions, particularly patients on immunosuppressants, they may require dose adjustment. One may consider stopping statin for a while, re-challenging, or use lowest dose on alternate days, rosuvastatin 2.5 milligrams, for example, or 1 to 2 times a week, and then titrate it up. And you will succeed in many such patients who otherwise may be deemed to be a failure to statin. And finally, add other agents such as ezetimibe and now PCSK9 inhibitors or even bempedoic acid. So we have multiple choices now in consideration of novel and emerging options for LDL cholesterol. PCSK9 inhibitors have been around now for more than 7 years. There are 2 of them, monoclonal antibodies, or we now have siRNA approach. Actually, Merck is developing an oral PCSK9 inhibitor, but it'll take some years before we know. Bempedoic acid, I'll say a few words about. Very easy to take oral drugs, unlike PCSK9 inhibitors that need to be taken every 2 to 4 weeks by injection. This is an oral drug by a different mechanism. It was approved for secondary prevention for patients with FH after statin plus ezetimibe trial. Not yet approved for primary prevention because the clinical trial is in progress. Avinacumab, I won't dwell on, $1 million a year drug, extremely rarely used, but approved by the FDA for patients with severe FH as of last year. And there are some thyromimetics being developed once again. These have a kind of difficult past tenure, but now they're more specific receptor agonists, beta agonists that are under development. And CRISPR technology is now being used, or at least tried, in certain in vivo and in vitro studies, and even human trials are beginning to take place. So very exciting field right now to look at people who cannot get to goal by statin alone. Okay, a couple of things about PCSK9 inhibitors. We all know that PCSK9 is an enzyme that is secreted by the liver, and it comes out of the liver in secreted form, and it binds to the LDL, an LDL receptor complex. As the LDL particle is internalized, The problem is that once it gets into the liver cells, it destroys the LDL receptor. So the LDL receptor cannot be recycled. There are two ways to undo the problem. Either you can make an antibody to the PCSK9, so there's no more PCSK9 to prevent the recycling of the LDL receptor, or you do a smarter move where you stop the synthesis of PCSK9 by this rather exciting new technology called the siRNA. We will hear more and more drugs coming out in this field, in lipids as well as oncology and other areas. So by preventing the synthesis of PCSK9, you don't have any PCSK9 available, or very little, if any. So both of these approaches are being tried. There are 2 trials with PCSK inhibitors, 48 trial with avulokamab. I believe avulokamab is available in India now. You can see here, all of these people had prior cardiovascular disease and were on high or moderate intensive statin therapy, very large number, 27,000 people. You can see they started with LDL cholesterol of about 83, 84 after being on previous therapy, and that immediately came down to about 30 milligram median. This is how effective these drugs are. 60% reduction on top of maximal statin dose with or without ezetimibe. So very, very effective drug. Same thing with alirocumab, very similar drug, again injectable every 2 weeks to every 4 weeks, as with avulokamab. Again, a 60% reduction, slightly higher to begin with, but then came down to about 40. And these are the kind of trials that led to the new awakening in the field that it is safe and it doesn't cause side effects other than local skin reactions, and we can achieve our goal. So speaking of the goals, major cardiovascular outcomes, unfortunately, both of these trials were terminated early because the curves were diverging, but you can see a highly significant, exactly 15% reduction in both trials over the course of less than 3 years in these trials. And if you look at just the 3-point MACE, sorry about that, CHD death, non-fatal MI, or stroke, not shown here, that is reduced by 20% instead of 15%. So they're highly effective drugs and now being widely used. Only major limitation is the cost, which hopefully will come down even further. Just want to point out a couple of things. Unlike statins, they don't seem to cause myalgia. Unlike statins, they do not seem to have increased risk of new onset diabetes, at least so far that we know, because that is an occasional problem in primary prevention with statins. And finally, if somebody wants to know, well, what about such low LDL cholesterol of 30 and 40? Well, they did extensive battery of neurocognitive tests, and they found that after multiple extensive testing, there was no change in neurocognitive events. Now, I would not say that this is a done deal because the trials were only 2 years long or 3 years long, and they did not include, patients only above the age of 75, let's say, and followed them for several years. So I would still say this is the reason why my goal is not to let the LDL goal currently go below 40 in older people and preferably closer to 50, 55. Okay, inclisiran is a novel siRNA approach, as I mentioned. It is very similar in its efficacy, maybe slightly less. And the advantage of this agent is that you use it at 3 months after your first injection, and then every 6 months thereafter. So in this particular study, of the many studies that were done, you can see that by every 3 months, every 6-month approach after the first 3 months, the LDL cholesterol went down about 58% and persisted throughout the year or so of this study. And cardiovascular trial with this drug is currently in progress, and hopefully we'll see the results in about a year or so. So please be on the lookout of that. But it works in a very different, very similar mechanism as the other PCSK9 antibodies. Okay, now let's move on. And I think it'll be exciting just to introduce the concept of this new company that just started a gene editing approach to PCSK9 in patients with familial hypercholesterolemia. This is a very, very actually innovative and amazing technology that one of the people in Boston recently developed, Sekar Kathirasan, at MGH and started his own company. So basically, it's a clever design with the gene editing approach. We not only take out the PCSK9 gene, but replace it with the normal gene. And you see the LDL cholesterol reduction of 60%. This one is a study in monkeys, but the first study in clinical trials has just begun in New Zealand. And the idea is you are in the doctor's office once and you are done. Once in lifetime. Okay, that's the hope and that's the goal. Because once you change the gene, you don't have to worry about any drug in the future. So I just wanted to bring you up to date on where we stand in the most modern technology. Okay, bempedoic acid. Bempedoic acid is actually a very interesting drug. It works on the same mechanism, actually, in cholesterol synthesis pathway. So you know that cholesterol is synthesized by multiple steps, all the way from citrate down the line to cholesterol synthesis. And statins block this key enzyme, HMG-CoA reductase. So by blocking this enzyme, you reduce the cholesterol synthesis. But on the other hand, bempedoic acid works 2 steps higher, more proximal, by this enzyme called ATP citrate lyase. And the good thing about this enzyme is that this is a prodrug. Not only that it blocks the synthesis of cholesterol, but being a prodrug, it's selectively activated only in the liver, so there are no muscle side effects that sometimes are seen with statin. If you look at the efficacy studies, unfortunately, it's not as potent as statin, but it is fairly good in its efficacy. These are the efficacy studies, 2 different studies. You can see about 18 to 20% reduction in the LDL cholesterol. In the other 2 studies, which were done in statin intolerant people, there's almost a 30% reduction compared to placebo, maybe because the baseline was a little higher in these groups. I should mention that the cardiovascular outcome trial is likely to come out not this year, now that we're at the end of this year, but next year. And it does seem to have lower risk of new diabetes, not only neutral, but lower risk because of the property of the enzyme ATP citrate lyase. And finally, there are a few nuances, like about 1% increase in the uric acid and some recurrence of gout. So be careful in such people, slightly elevated liver enzyme changes that are reversible, mild decrease in GFR, etc. But again, very easy drug to use. And the question you might ask, well, if it lowers LDL by about 20%, and you have drugs like ezetimibe that lower LDL cholesterol by 15 to 20%, why not combine the 2 drugs in one single pill, fixed drug combination? That's exactly what was done. In this next slide, you can see that these were people who are on ezetimibe, and they were given bempedoic acid or placebo over the course of 3 months in the statin intolerant patients. And now look what happens. On top of ezetimibe, there was another 24% reduction in the LDL cholesterol. So that's a wonderful combination that can be used. I'm not sure if it's available in India. It's already approved by FDA, both the monotherapy and the combination therapy. Okay, now in the remaining part of my talk, I wanted to bring you up to date on this residual risk. We know that more than 30 to 40% of recurrent events occur in statin and ezetimibe treated patients. What are the possible reasons? One we already talked about, LDL goal. If we lower our goal to say 55 from 70, will we undo this residual risk that keeps on occurring? The best calculations suggest probably not, because we might get another 10% or 15% reduction. We'll still have about 20 to 25% of people who will keep having cardiovascular events. To make the long story short, it seems like we forgot about triglyceride-rich lipoproteins because we were paying more attention to HDL cholesterol. But now it turns out that triglyceride-rich lipoproteins, because they contain this remnant cholesterol, are equally atherogenic than compared to LDL cholesterol, and maybe a few other reasons. So just wanted to show you this. then when the triglycerides enter the cell, they get degraded by this enzyme, lipoprotein lipase. They became smaller and they are procoagulant and pro-inflammatory. More importantly, once the cholesterol comes out of this particle, this remnant cholesterol enters the macrophages and becomes foam cell. And think of this as being very similar to the LDL cholesterol pathway. So the reason why triglyceride particles are atherogenic, not because of triglyceride per se, but because of the residual cholesterol that circulates that causes this additional atherogenic damage. Okay, I'll get into that maybe if time permits. But currently, there are a number of drugs being developed, not only what we have, but in addition to the new drugs that will be improving the activity of lipoprotein lipase. And I mentioned already fibrates work on this mechanism partially, but ApoC3 is the main inhibitor of this enzyme, as are many others. So there are new drugs being developed against ApoC3 or against angiotensin PTL3 and 4. You will hear a lot more about it in the coming years. Okay, first approach for high triglyceride in anybody is to treat secondary factors, lifestyle factors, weight loss, okay, cutting down the carb, particularly fructose, hyperglycemia management, comorbidities, hypothyroidism, CKD in particular, reducing proteinuria if you can, and many offending drugs, including HIV, protease inhibitors, immunosuppressants, etc., estrogens as well in some susceptible cases. Okay, now, as I alluded to before, the clinical trials that have been carried out in people with LDL cholesterol having been achieved in optimal range, how to target the triglycerides in HDL. Well, you all remember Accord lipid trial, where mean LDL cholesterol was 81. So this was the first and only trial up until 2-3 years ago, where everybody was on statin. And having been on statin with a reasonable LDL, they got statin alone with placebo or fibrate, fenofibrate. And these are pretty large number of people, 5,500. And you can see that down the line, unfortunately, the outcome was neutral. Okay, no significant benefit, which was surprising because we've been using this drug in the hope that they improve cardiovascular outcomes. However, if you look at a small subgroup of only about 18% of the total cases, 900 cases, who had high triglyceride above 200, HDL less than 34, they had a borderline benefit. Again, numbers were small and we couldn't be sure. The two niacin trials, both with LDL cholesterol 64 and 53, statin-treated people, when they use niacin, you can see both of these trials. One was people with diabetes and metabolic syndrome, no benefit, and the other much larger trial with statin and niacin as well, compared to statin alone, no benefit. Even they had 32% people with diabetes. So we struck out after so many years of use of niacin that raising HDL cholesterol is not going to help. CETP inhibitors also, which I don't have time to go into. But the Accord lipid trial raised the question. I think we need to do another study, everybody felt, where we selectively take people with triglycerides over 200 and HDL maybe less than 40 or so, and see what happens in a large number of people with type 2 diabetes with statin plus fibrate combination. And not only fenofibrate, but let's use a better drug, a more potent drug, a newer, more selective drug is called pemafibrate. So we have had some new revelations in the hypertriglyceridemia field with the newest trial that was just presented at the AHA just last weekend on November 5th. So you can't ask for a more recent trial than that. This trial is called Prominent. Many sites were part of it throughout the world, including a few sites in India. We at Joslin were part of it. 10,000 people, only people with type 2 diabetes, as opposed to Accord, where people had heart disease here. It was a combination of heart disease and cardiovascular risk factors. So in a way, similar to the Accord trial, but very large number of people with triglyceride between 200 and 500, HDL had to be less than 70. All of them had to be on moderate and high-intensity statin therapy. And to get into the study, the LDL cholesterol had to be less than 70 or less than 100 if you're statin intolerant. Okay, to make the long story short here, the trial was completed and we were all very, very optimistic about the cardiovascular outcomes coming out positive, but unfortunately, that was not to be the case. First of all, show you the main lipid effects. The triglyceride went down by 26% as expected. Remnant cholesterol that I've been talking about went down by 26%, just like LDL cholesterol. That's good news. Apoprotein C3, I alluded to, went down by 28%. All of that, very good news. But look at what happened subsequently if you look at the other risk factors. This is known to happen with fibrates, that the LDL cholesterol goes up modestly, and it did go up 12%. Not only that, but if you look at just the ApoB level, it went up by 5%. ApoB, in many people's opinion, is a very important determinant of cardiovascular events. It usually reflects the LDL cholesterol, and it may still be high in people who have high triglycerides after fibrate treatment. So this has been well known. The bottom line is that these are the results from prominent study. A large study, as I mentioned, more than 4 years of follow-up, and published in New England Journal the same day on November 5th. I'll encourage all of you to look at the results. These are the primary outcomes: MI, stroke, coronary revascularization, or CV death. The two curves are superimposable. No difference whatsoever. Very disappointing. Hazard ratio of 1.03. So based on this, even though we will definitely have more sub-analysis, other subgroups that need to be looked at in this very large trial, but right now, you have to say that there's no way FDA is going to approve this drug for cardiovascular event reduction. Neither has fenofibrate ever been approved for cardiovascular risk reduction. What else happened in this trial by way of safety? Surprisingly, there was a 12% increase in the adverse renal events. Occasionally, that's been shown with fibrates early on, but this was persistent. On the other hand, the hepatic adverse events, if anything, went down, 17% reduction, looking at the liver enzyme. People used to think, oh, fibrates may raise liver enzyme, but actually it lowered it. If you look at just non-alcoholic fatty liver disease, by scanning that they performed, it was actually reduced by 22%. So if any good thing that you can talk about right now, and further work is needed to do yet another trial or look at it in much more detail, that the NASH may go down with the triglyceride reduction. And finally, I should also mention that there was a slight increase in venous thromboembolism and pulmonary embolism. So what are we left with? The only thing that we're left with that we can hang our hat on is the REDUCE-IT trial, which by now you know very well. It was a study that I was a co-investigator in for a number of years from the very onset, and I may have presented this data before, but I'm not sure to this audience that in this particular study, we used a very purified omega-3 fatty acid called EPA, which has been available by prescription for a long time. 8,000 people, 70% were men. Everybody had to be on statin. You can see that the median LDL in the study at baseline was 75, not bad at all. Triglyceride moderately elevated, 216, 150 to 500 was the inclusion criteria. HDL less than 40, actually median was 40. 60% or so had diabetes, and about 30% had diabetes, but no prior cardiovascular disease, just multiple risk factors. In this trial, as expected, again, triglyceride went down, LDL cholesterol actually went down, which is a unique effect that was not seen in the fibrate trials. And the CRP went down, and the EPA level itself went up. We measured the EPA levels throughout the study. And we were actually equally positively shocked by the results, just like we're equally negatively shocked by the pemafibrate trial. 25% reduction on top of statin in major coronary and atherosclerotic endpoints. If you look at just the three major MACE endpoints, again, 26% reduction, and the curves were still diverging, even though it was a 5-year study. And one interesting part of this was that even though the triglycerides went down, even though we have such wonderful results, but if you look at the tertiles of triglycerides, lowest tertile, median tertile, highest tertile, it didn't make any difference whether you had the lowest triglyceride or the highest triglycerides. Within their range, mostly 150 to 500, all of them had equal benefit, about 23 to 40% or so. So I think it's very clear by now, as was shown in the older studies, such as VA HIT, that even though in some situations triglyceride reduction may help, depends on which drug you use, but that may not be simply explained by triglyceride reduction. So what causes this difference? Just one word about the side effects. There was slight increase in the bleeding episodes, not significant, 2.7 versus 2.1. And there was a significant increase in atrial flutter fibrillation. Again, small number, 3% versus 2%. So you have to keep that in mind in people with active AFib. Okay, there was another study with exactly the same design as the REDUCE-IT trial, which came out a year or so after the REDUCE-IT trial. You can see here, very large study, same LDL cholesterol 75, triglyceride 240, and HDL cholesterol 36. But here, whether you look at 5-point MACE or 3-point MACE, absolutely no difference. The only difference between the two studies was that in this particular study, a combination of EPA and DHA was used, whereas in REDUCE-IT trial, only pure EPA was used. So that is now the recommendation all over the globe by all the major guidelines that on top of statin, for people with residual triglyceride elevation, use pure EPA, not the combination of the two. Okay, so why is the EPA so unique among omega-3 fatty acids? Why does and how does DHA undo what EPA does? Because that's what appears to be the case based on these two trials. Well, we have a long way to go. We are now actually the active labs looking at particularly Preston Mason's lab in Boston area. We published this review a couple of years ago to point out several differences between EPA and DHA, where EPA appears to be much more anti-atherogenic by improving endothelial dysfunction, by reducing inflammation, and by stabilizing the unstable plaque. And part of this may have to be the membrane fluidity and structure, because DHA does not create the monolayer crystals as the EPA does. A very long story, but much more needs to be accomplished before we can really surmise the exact mechanism. So to summarize what I've said, I would say that in a patient who has cardiovascular disease or who requires reduction of very high risk of cardiovascular disease, the first goal is to use maximally tolerated statin. No question about it, no debate about it. And then in such people with high LDL cholesterol, use ezetimibe or PCSK9 monoclonal antibody, one of the two. And if a person has, in addition to persistent high LDL, if they have triglyceride between 135 and 500, according to FDA recommendation, then consider adding icosapent ethyl to reduce the residual risk much further. Bempedoic acid is a good option in secondary prevention. So is the PCSK9 siRNA inclisiran, but both of these trials are currently underway. And by next year or two, we'll have the results of these. But in the meantime, bempedoic acid and PCSK9 siRNA inclisiran, they're both approved in patients with pre-existing cardiovascular disease. A word about lipoprotein A, because I know many of you are aware that LPA is genetically determined and in fact generally tends to run a bit higher in South Asians. So over the years, even though we've known about this lipoprotein particle for more than 60 years now, this is the AHA scientific statement published where they reminded people about the fact that LPA is an additional apoprotein that is combined to the lipoprotein ApoB, and this makes it much more atherogenic. It is prothrombotic. It induces more unstable plaque, and is also involved through its phospholipid component in aortic valve calcification. So there are a lot of good reasons to consider LPA reduction. But unfortunately, so far, none of the drug trials have been completed to show that the reducing LPA on top of LPA reduction, LDL reduction, will be additionally beneficial. Some people strongly believe in that, are already using drugs like PCSK9 for this reason. This is a study we published a few years ago based on 9 different RCTs in patients with diabetes and cardiovascular disease, showing that unlike statins, they do not lower LPA, but PCSK9 inhibitors lower it by 30%. But the question still remains, is that enough? Do we need a reduction in LPA much more than 30 or 50%? That is why I insist that we look at the trials as they come out. And in the past couple of years, again, there are a number of review articles that have come out. European Heart Journal, Journal of Clinical Journal of Clinical Lipidology, National Lipid Association, AHA scientific statements. All of us are trying to remind us that we have to look for trials like this, which is currently underway, which is looking at a siRNA technology again, Pelcarsen, which is LPA antisense oligonucleotide inhibitor to block the LPA action. So I think until that kind of trial and one more that is being planned is completed, we cannot provide the final answer. Okay, so I think at this point, let me see if I have missed one slide. Somehow I lost the show here. Okay, concluding remarks. I just wanted to take a minute or so to provide some concluding remarks of a lot of stuff I tried to bring out in this session. Okay, number one, major RCTs over the past 25 years have established the predominant role of LDL cholesterol in ASCVD event risk. When statin alone is not enough, several novel options are currently available or in trials for getting LDL cholesterol to goal. New evidence from genetic studies and prominent trials with pemafibrate have highlighted the importance of triglyceride-derived remnant cholesterol. No doubt that this was highlighted very well in pemafibrate, and it did explain the residual cardiovascular risk after achieving LDL cholesterol target. But the fibrates are not yet able to reduce CV risk in statin-treated patients, including fenofibrate and pemafibrate, and also the older fibrates. Icosapentaethyl is the only evidence-based omega-3 fatty acid for cardiovascular event reduction, but the precise mechanism is likely beyond triglyceride reduction, as I mentioned. Fibrates are still indicated for patients with severe hypertriglyceridemia. So I have to mention the fact that when you see patients with triglycerides over 500 and closer to 1,000, not very common, but about 5% of people with uncontrolled diabetes will have chylomicronemia syndrome. These people have increased risk of pancreatitis, and it's a condition that leads to hospitalization as an emergency and potentially lethal condition. There's no debate that this condition can be prevented, at least partially, by maintenance of triglyceride in under 500 range in prophylactic use of fibrates, and should be considered, if not before, but after the episode of acute pancreatitis, should that bring the patient to the hospital. And lastly, ongoing trials to address LPA are addressing its independent role in ASCVD events. With that, I want to thank you all very much and I'd like to invite your comments and questions. Thank you very much.
Thank you, sir. A great exposition and beautiful discussion about whatever is going on in the field of lipidology. And I think something very important, because when we focus on glucose control in diabetes, of course, that is important. When we focus on glucose control, we forget that there are other numbers also that we need to look at. From Indian philosophy, sir, we are reminded of the metabolic quadriga. So when you see our chariots, they were run with 4 horses. And quadriga is a Latin word which is a chariot that is run with 4 horses. So when you see the picture of the Mahabharata, for example, you will see that those 4 horses are fighting evil. They are fighting the enemy. And in diabetes, the quadriga, the metabolic quadriga, is glucose, blood pressure, body weight, and also lipids. So thank you, sir, for highlighting this oft forgotten aspect of diabetes care. Sir, a lot of greetings coming from you from across the subcontinent. Dr. Altaf Chima from Lahore sends you a salam. And people from all across India are greeting you. Let's try to structure the questions one by one. And one question coming in is, we have a patient with high glucose and high lipids in general. Should we start glucose lowering therapy and statins simultaneously, or should we start sequentially? This question is from Dr. Vinod Dhandania, who is a very senior diabetologist from Jharkhand.
Yeah, thank you for those questions, and thank you for joining and your wonderful question. So I think this is an important question for practical care of patients. And I think there is no real argument in people who are above the age of 40, who present with diabetes, who have LDL cholesterol above 70 at the time of presentation. One of the facts that often can be sometimes put aside is that glycemic control helps triglycerides a lot more than it helps the LDL cholesterol. So unless you feel somebody has very poor control and his LDL cholesterol is borderline, excuse me for my cough, then this kind of person, perhaps you can improve glycemic control and then reconsider statin therapy. But if somebody has hemoglobin A1C around 8% or less and have LDL cholesterol that is clearly elevated, then I think there's no reason not to start statin therapy at the same time. And in most people above the age of 40, almost everybody I can think of would be a candidate. But again, we talked about people above the age of 75, where we need a little more evidence in primary prevention.
So you've said, sir, that usually it will be a simultaneous initiation, but you can consider sequential if the risk is different, and you might want to stratify your patients according to initial HbA1c. If it's very high, and if you are confident that you can bring it down, and you have a feeling that with the lowering of HbA1c, TGs will come down, then you can hold your horses. Sir, a similar question, and this is from Dr. Anshul Singhai from the neighboring state of Chhattisgarh, neighboring to Jharkhand. You've spoken about using HbA1c as a means of taking a clinical decision. What about triglycerides? If triglycerides are more than 500, we initiate statin and fenofibrate. When the triglycerides come down to normal, do we continue the same therapy, or do we de-escalate? Should we stop fenofibrate once the triglycerides have normalized?
Yeah, that's another important question. So I think it's very clear that people who have moderate hypertriglyceridemia in the range of 200 to 500, don't forget that statins also lower triglycerides, about 20 to 25%. So one important rule is, if you're a person with diabetes who are at a high risk for cardiovascular events, who have triglyceride less than 500, focus on the LDL cholesterol first and see how much reduction in the triglyceride you get with the LDL cholesterol and triglyceride reduction with statin alone. But the triglycerides are in that same range, but the person has very high risk of cardiovascular event. I would still go after the LDL and non-HDL cholesterol goals and intensify statin therapy first. Because there's no, as I showed you now, evidence after evidence, and now with the pemafibrate trial, there's no good evidence that cardiovascular risk reduction will be achieved by adding fibrate. So this has actually opened up a whole new area of reconsideration of fibrates, just like we did for niacin a few years ago with the HDL raising trials. So it's not clear what we're going to achieve by adding fibrate in someone LDL cholesterol less than 500. But to come back to this question, the triglyceride less than 500. So come back to the question that are actually very important question. If the triglyceride is over 500, and let's say we achieve glycemic control, we got patient to listen to the dietitian and achieve as much weight reduction as possible. Cut down on the alcohol. I should have also mentioned lifestyle. And stop smoking because they also raise triglycerides. Do all those things. And the triglyceride remains still over 500. Then you consider a fibrate, but if it remains under 500, I don't think there's any good reason scientifically to add fibrate. So if you had this patient on fibrate to reduce the triglyceride from well over 500 when you started it, now may be the time to even discontinue it and just follow the patient with, again, much more emphasis on lifestyle factors. And I can tell you within the next year, new guidelines will be coming out from everywhere after more extensive analysis of the pemafibrate study that I just provided the details about.
Thank you, sir. And that answers the question from Dr. Vinay Desai, who asked about the importance of non-HDL in lipid profile. You've mentioned that, and also triglycerides more than 500. Certainly, they must be treated. And you've put in perspective the role of fibrates, when to use, and how much to expect from them. Actually, you've given us a reality check about them.
Yeah. So, non-HDL cholesterol is a good marker to look at. ApoB is even a better marker in people with high triglycerides. I know it's not routinely done. We do it routinely in everybody who has got triglyceride over 200 or fasting triglyceride over 150. We do it routinely because it's a better marker than non-HDL. But it's okay to just look at the non-HDL cholesterol in people with high triglyceride. And people with normal triglycerides, it doesn't matter. So once again, I would again emphasize that even if the non-HDL cholesterol is high, which most likely means your remnant cholesterol is high. Remnant cholesterol is simply total cholesterol minus HDL cholesterol minus LDL cholesterol. So you know that the remnant cholesterol really represents non-HDL cholesterol in many cases, but it's better to calculate it that way. And this way you don't have to do ApoB. But the remnant cholesterol being high, I would still go with more intensification of statin therapy. And if you don't get to LDL cholesterol goal, add ezetimibe after statin. And as we were talking prior to starting this conference, even consider bempedoic acid. Once it is approved, I should caution you, you can use it. We physicians can do whatever we want, but it's not yet approved for primary prevention. But in secondary prevention, for sure, bempedoic acid is already approved. And finally, PCSK9 inhibitors. So keep on emphasizing on LDL cholesterol. Once you get to LDL cholesterol less than 70 in high-risk people, or less than 50 or so, 55 in people with pre-existing cardiovascular disease, if your triglyceride level is now still high, okay, then you are in a quandary. Okay, emphasize more lifestyle. Should we add fibrates? Scientifically, no reason. But by then, my guess is that your triglyceride level will come down to a more appreciable level.
Yeah. Sir, this question from Dr. Suresh Bhagra, you've been speaking about statins. Is there a difference in the safety of statins with regard to new onset hypoglycemia? Should we prefer anyone over the above?
Well, first of all, it is true that more intensive statin therapies are more likely to cause new onset diabetes. So here we may be talking about primary prevention in somebody who has had cardiovascular disease who does not have diabetes. So you're concerned and the patient is concerned, and patient comes and asks you, why do you want to put me in statin, particularly in primary prevention? If I don't have diabetes, I don't want to get diabetes. Keep in mind that most people who get diabetes already have pre-diabetes. It may not have been ruled out. So look at these people carefully, not only with A1C, but fasting blood sugar and postprandial blood sugar. Because as you know, we can miss some people by doing one and not the other. So if they have pre-diabetes, they should be informed about their choices of lifestyle intervention rather than going on a statin and thinking that now I can eat whatever I want. That some people do. So regarding the choice, again, if the LDL cholesterol is not very high, you can use less intensive or moderate intensive statin therapy, such as atorvastatin 10 to 20, or pravastatin, 20 to 40, or even simvastatin. So I think moderate intensive statin therapy is less likely to cause increase in the glycemic levels.
You spoke of pre-diabetes, sir. So let's move to a few questions about specific situations. And this question from Dr. Anshul Singh. In a person with pre-diabetes, you mentioned that we can use statins, just be moderate in your intensity. But what are the indications and the targets, the thresholds and the targets for initiating lipid-lowering therapy? Will they differ between a pre-diabetes and a diabetes patient?
That's a very good question. There's never been a study on people with pre-diabetes alone looking at the cardiovascular outcomes. We have a lot of observational long-term follow-up studies that show that the risk of cardiovascular outcomes is somewhere in between people who don't have pre-diabetes, those who have pre-diabetes, and those who have type 2 diabetes. Because people with pre-diabetes often have hypertension, they have central obesity, and they have high triglycerides and low HDL cholesterol. So I treat them with a little bit more intensity than I treat somebody who is totally non-diabetic, non-pre-diabetic. So again, I think one of the handicaps we have is you can't calculate their 10-year risk very easily because none of the risk equations include pre-diabetes. Secondly, even in people with diabetes, there is no role of family history in calculating their 10-year risk. So I look at them with more suspicion if they have strong family history of cardiovascular disease. I don't know how often you do, and you can tell me about this, Sanjay, that people go for coronary calcium score. One of the things that's highly recommended, two things actually. One is you look at their CRP, which can be easily gotten, high sensitive CRP, or you send them for a coronary calcium score. If the coronary calcium score is elevated, then your index of suspicion to start them on statin therapy should be even sooner.
Yes.
So is it being done very commonly in India?
No, not frequently. But if you want an objective parameter, of course, you can do the lipid profile. And you will do note, this is speaking to all the audience, that each laboratory will have their own normal lipid profile, printed. And that was printed 20 years ago. So just do take the opportunity to tell all your patients that the normal lipid profile is based upon their risk stratification. So
Right.
each person will have a different target.
Right.
So that is something we should tell. You can use the QRisk 3, which comes from the United Kingdom, a free tool. QRisk 3, you can put in Indian ethnicity, and that will give your patients the risk of cardiovascular disease. It takes seconds, and it is quite effective, actually, if you want to counsel your patients in the clinic.
Sure.
Sir, sticking to special situations, one question coming in from Dr. Anshul Singh and also Dr. Ashutosh Das. So let's take the series of questions. Is this correct that in chronic kidney disease, everyone should get a statin? Is it correct that everybody with CKD stage 5, that is end-stage renal disease, should get a statin? And if so, which one is your preferred choice?
Very important question. First of all, CKD is often being missed, even in countries like United States. Every patient with diabetes, type 1 or type 2, should be screened for CKD. Type 1, 5 years after the onset, type 2, every year after the onset. And it's not enough just to do the GFR by calculation from creatinine, but also look at the albumin creatinine ratio. We know from evidence that we have over the years that increased ACR increases the risk. The reduced GFR increases the risk. And then combined, the two of them increase the risk even further. So CKD is a very high risk condition for atherosclerosis. And people who are with advancing CKD, many will die of cardiovascular disease before they even get to dialysis or transplant. So particularly in patients with stage 3B and stage 4 CKD, by which I mean GFR between 15 and 45. These are at much higher risk of cardiovascular outcome in the next several years than people who have GFR above 60. Even between 45 and 60, the risk begins to increase. So make use of the GFR and the albumin creatinine ratio. And there are new studies that have come out now in the CKD field, and the KDIGO guidelines, which is the international kidney guidelines. They highly recommend the use of statins in people who have any evidence of nephropathy, except for patients who are now on either pre-dialysis, GFR less than 10, or already on dialysis and waiting for transplant. Because in those conditions, there are trials that have been done in people on dialysis, and they did not show a clear-cut benefit. But there are millions of people out there who have GFR between 15 and 45, and some will argue 10 and 45, who clearly are candidates for statins.
In fact, the kidney guidelines
And
mention.
the part of the question was which statin to use.
Yeah.
So it doesn't really matter, depends on the LDL level at baseline. I use almost all of them. Atorvastatin is my first choice in such people. Rosuvastatin is also something that is often used, or the weaker statins if the LDL cholesterol is borderline and you're not looking for a very big reduction in the LDL cholesterol.
The renal guidelines also recommend that you can start statins irrespective of the baseline LDL. So you don't even need to wait for the report to come. It is that clear-cut an indication. Sir, some more questions if you allow. Dr. Anshul Singh thanks you for the answers and mentions that we do apolipoprotein also in India. It's easily available. We had spoken of specific situations. Let's talk about some lifestyle modification related questions. So Dr. Syed Kadri queries you. In a person with diabetes and dyslipidemia, is it essential to stop eggs and meat totally?
Stop what?
Eggs and meat. The background, sir, is that in India, there is this conception, there is this common thought process that eggs, especially egg yolk, worsens cholesterol and it should not be given to anyone with diabetes.
Yeah, so I think it's all additive. Depends upon what your rest of the intake is. There were new guidelines that were published about 2 years ago from the AHA and the dietary subcommittee, which said that cholesterol itself does not raise LDL that much. So it's okay to have eggs. But they were talking about people in general population. There is some evidence based on some studies published in the nutrition literature that people with diabetes are more susceptible to a rise in cholesterol, LDL cholesterol, with egg yolk. So I would say it's a good recommendation to reduce the intake of egg yolk. In addition, more importantly, to cut down the intake of saturated fat. So even lean red meat may be okay for some people if they cannot avoid it, but they should trim all the fat from around it, which is loaded with saturated fat. And finally, I think, milk is very commonly consumed. Cutting down the milk consumption or making it, not cutting down the consumption, but reducing the milk to 1% or skim milk will help. Depends on how much reduction you're looking for, and switching from hard cheeses to soft cheeses. All of these things will collectively reduce LDL cholesterol. But again, I should emphasize, and this has been learned the hard way, that even a very strict diet with low fat, low cholesterol will lower your LDL cholesterol probably no more than 15% in the long run. Okay, you can do it in 6 weeks in a laboratory CRC situation, and you can lower it by 25%. That's not practical for most people. That is why the use of statin is so important, because you're looking for much more than 15% reduction in most cases.
So from an Indian perspective, actually, the message we are getting is cut down on ghee, that is saturated fat, cut down on full cream milk. And lean meat may not be such an issue, but it's, more of the butter chicken and cream chicken, which causes a problem, not just the chicken.
Yeah.
And sir, I'm reminded of this Punjabi movie. You must watch it sometime. Love Shavte Chicken Khurana. And why I like this movie a lot, Love Shavte Chicken Khurana, because it's a nice movie. It's a happy movie. And it's been shot in a village called Lalto Kala near Ludhiana. And Lalto Kala happens to be the rural outreach center of Christian Medical College Ludhiana. And with that happens to be my alma mater. So that is why we recommend Love Shavte Chicken Khurana. And it's a happy movie. You will feel happy when you watch it. Maybe your blood pressure and cholesterol will come down slightly. Yep.
Thank you.
Sir, if you allow just a couple of more questions, short answers. We still have one more question from lifestyle modification. This comes from Dr. Ashutosh Das. So you said, sir, don't eat ghee and don't take full cream milk or take it in moderation. But which oil should we recommend to our patients for cooking?
This is another important question. Actually, believe it or not, there are hardly any randomized studies in this regard. There's a famous study called the Nurses Health Study in Boston area, carried out right across from where I work, Women's Health Study, and the other long-term, very large epidemiological studies, observational studies. There are a few randomized control trials short-term. And actually, reducing LDL cholesterol is more possible with polyunsaturated fat than with monounsaturated fat. But monounsaturated fat has other anti-atherogenic effects besides lowering cholesterol, which is more modest. If you look at the study, the famous study, the Mediterranean diet study that was published in New England Journal, and then another one that was published later on. In the Mediterranean diet, most of the oil is olive oil or the nuts, walnuts and other nuts, walnuts in particular. So I think both the non-saturated fat oils are good. I'm still waiting to see a good study, somebody do and show me that coconut oil, which always comes up, is a good substitute or not in any situation, because it's pretty saturated, just like the palm oil. So I really think somebody from India should probably think about doing a study in that regard. But for cooking on a daily basis, I would still emphasize that, and in my home, we alternate. This is how much we know. So one week we use olive oil, and 1 week we use corn oil. So because we're still waiting for more data. Yeah. But I think both are good.
That question was from Dr. Ashutosh Das. Sorry, I messed up and I said Ashutosh Khurana. That was the impact of chicken, and maybe it tells us that we are all getting hypoglycemic. But an Indian perspective would be, number one, let's reinforce what sir is saying. The total quantity needs to come down. The total quantity of ghee and cooking oil needs to come down. Number two, there is no evidence to say that one particular oil is the best. So you take a little bit of everything. Alternate, or maybe the housewife might want to say, I'll cook some vegetables in mustard oil and some others in corn oil. If you want an equivalent for olive oil, that is Mufa rich, the best sources in India would be mustard oil and groundnut oil. Of course, nowhere near that 75% Mufa in olive oil, but still it's 52, 48, 48, 52, 48%. So mustard and groundnut is what we would suggest.
And I think you bring up another point, that mustard oil is probably the only oil I can think of which is rich in omega-3 fatty acids.
Yes.
So
yes.
I think that's something to keep in mind. And and again, the greens have some omega-3 fatty acid as well. Even in countries like India, where people often are vegetarian, it's important to keep in mind not to limit the consumption of vegetables, especially green vegetables and fruits. And studies from China and Japan have actually have come out, which are randomized controlled trials in some cases, small studies, but they show that the consumption of vegetables and fruits does improve the overall cardiovascular outlook.
So when we have children coming into us, sir, we ask them how many colors there are in the Indian flag. So immediately they'll say 3. Then you ask them to think again, they'll say 4. So we tell them, if you want to be patriotic and healthy, you must have at least 4 colors in your plate.
Yeah.
So that is the way of getting them to take colored vegetables, fruits, and salads.
That's
So
great. Great advice.
just a couple more questions left.
Yeah, I
Dr.
must
Anshul,
inform you that I have a meeting in about 5 minutes.
yep,
But
we'll
anyway,
finish, sir.
please go ahead.
But I'll
Mhm.
continue. So please keep on asking your questions. We acknowledge the questions by Dr. Subhash Chandra Patra, Dr. Asmatullah, not directly related to Dr. Om Ganda sir's topic, but direct related to diabetes. So I'll take them up in 5 minutes. Dr. Anshul Singh says, sir, in one sentence, statins increase the risk of diabetes in pre-diabetes. That worsens CV risk. Statins reduce CV risk. How do I balance? What do I tell my patient?
Yeah, tell them the following, and this has been calculated. If you treat 1,000 people who don't have diabetes but have cardiovascular disease for 5 years, about 5% will get diabetes. But in the same 1,000 people, you will prevent 15% of them from heart attacks. So there's no debate in my mind that even if you are at the cusp of getting diabetes, you still cannot ignore the importance of cholesterol reduction, and primarily with statin, of course.
And another question from him is, you've spoken of the PCSK9 inhibitors in familial hypercholesterolemia. Is there a minimum age to start this therapy? And is there a maximum age to end it?
Maximum age?
To discontinue PCSK9 inhibitor?
I'm sorry, repeat the question.
In a child with familial hypercholesterolemia, what is the minimum age at which we can start PCSK9 inhibitor?
Well, this is a perplexing problem. Actually, I've seen people refer to me from other places where children, of course, have familial hypercholesterolemia, LDL cholesterol, 250, 300, and so forth. So in such people, the minimum start age is age 2, believe it or not. But people with heterozygous familial hypercholesterolemia, with strong family history, the pediatric organization and the AHA recommend starting statin therapy at age 10. It used to be age 12, but age 10, except for homozygous familial hypercholesterolemia. Because they're going to get heart attack by the time they're in their teenage years, depending upon the level of cholesterol. So that's one exception.
Thanks. And one more question from Dr. Barun Kumar, and then we can thank Dr. Ganda for all his insights today. Any glucose-lowering drugs specifically which will tackle both hyperglycemia and dyslipidemia?
Yeah, I don't think of, we know that indirectly by causing weight loss, the GLP-1 receptor agonists do lower triglycerides. Okay, that's simply a reflection of weight loss. SGLT2 inhibitors actually cause a slight rise in the LDL cholesterol. The mechanism is unknown. So for triglyceride, it's easier. Glycemic control itself will improve triglycerides and thereby some VLDL cholesterol. But to lower LDL cholesterol directly with a glycemic drug, I'm not aware of any.
Thank you, sir. This question was from Dr. Barun Kumar. And I would like to thank you on behalf of everybody who is logged in for all your insights. You've actually made this topic so vibrant, so interesting for us. We will continue with the other questions. But before that, I'd like to invite Mr. Anang Basu from Team FDC to deliver a vote of thanks.
Thank you very much, Sanjay, for really very wonderfully moderating this session and helping me answer questions.
Sir.
Dr. Om, I think a wonderful word would be disrespect to you for this session you have taken today. Clarity and the mesmerizing talks which we got today for almost 1 hour, 20 minutes is, sir, wonderful for us. And I would definitely exchange mail with you, give you more tribute about the sessions. And so we would love to have next year as well, because the way we have been getting the updates and the lipid therapy and the lipid lowering drugs going the direction and the globally, the only one person we get to you is from Dr. Ganda. Thank you very much. And sir, we leave you with a great thanks.
Thank you for inviting me. It was my pleasure. And I was very happy to see the interaction from all the people who attended. And Thanks again to your team and Dr. Kalra.
Thank you, sir. Goodbye. Goodbye. We'll take a few more questions that have come. And this question from Dr. Asmatullah. What are the future treatment options for type 1 diabetes? So the best that we have today is insulin, but you can use different delivery methods or delivery devices for insulin. So you can use subcutaneous insulin. Basal bolus is what is suggested. But if you use an insulin pump, that is continuous subcutaneous insulin infusion, that is one advance. The quality of pumps that we have available in India have improved a lot. So feel free. The company that is available is Medtronic, and they have good models available. So that is the future. There has been a lot of work on monoclonal antibodies to prevent type 1 diabetes, but unfortunately, none of the studies have shown long-term benefits. Dr. Subhash had many questions, and I apologize, sir, we were not able to take them initially. Long-term side effects of metformin, gastrointestinal intolerance can come in any time. And secondly, vitamin B12 deficiency, especially in vegan and vegetarian populations. So you may have to supplement with vitamin B12 every now and then. Another question from him was side effects of sugar-free tablets. So if they are used in moderation, there is no major issue. However, there is discussion that if you use the artificial sweeteners in very high quantities, usually no patient uses in that high quantity, they can disturb the gut microbiome, and that can lead to a pro-inflammatory state. Safe glucose and safe lipid levels in an 80-year-old patient suffering from diabetes and hypertension. So in general, in an 80-year-old person, we will not be very aggressive. So assuming that there is no other comorbid condition and not too much of frailty, maybe a fasting of 125 to 140 should suffice. A fasting of 200 will certainly suffice. Our main aim at age 50 is to prevent osmotic symptoms and to ensure good quality of life. So that is all we have to ensure. If the patient says, I'm comfortable, I don't have to get up too many times at night to go to the bathroom, that's fine. If you become too aggressive and you cause hypoglycemia, actually it is possible that the patient may fall, and that can lead to an osteoporotic fracture. Regarding lipids, above the age of 75, data is really, really limited. So be very careful while prescribing aspirin. Give it only if it is established ASCVD. And also be careful while prescribing statin. There has to be a real indication for that. Don't give it for primary prevention. This question from both Dr. Balwant Akram Falake and Dr. Subhash Chandra Patra, treatment of diabetes in general, especially treatment of diabetes resistant to insulin. So our first line now is lifestyle plus metformin, lifestyle modification plus metformin. That should be given to everyone, provided that metformin is tolerated and is not contraindicated. If that doesn't work, you will add a second drug that can be sulfonylurea or DPP-4 inhibitor that is used routinely. But if there is a high risk of cardiovascular disease or the patient has got established ASCVD, then we would be better off choosing SGLT2 inhibitor or GLP-1RA. This would be our second line. SGLT2 inhibitors are oral. GLP-1RA are injectable once weekly, dulaglutide, once daily, liraglutide, lixisenatide, and oral also, semaglutide. So you choose between these. If the first line and second line together don't work, glucose levels don't come down, or maybe you began with an HbA1c more than 9, so you know that dual will not work, then you can start triple. So what will the triple be? It will be metformin plus maybe sulfonylurea plus maybe DPP-4 or GLP-1RA, just one out of them, plus SGLT2 inhibitor. Now, all this is assuming that your patient is stable. But if your patient is symptomatic, severely hyperglycemic, sick, in a special situation like pregnancy lactation, then the pragmatic policy would be to initiate insulin. You can start insulin for a short period of time. And once the patient recovers, you can always de-escalate and bring back to oral therapy. So this in a nutshell is how to manage diabetes. And we thank Dr. Patra and Dr. Balwant for their questions. With this, I hope that we've taken all the questions. In case there is anything missing, do let us know. And we'll always be in touch with you. Today was a mega show. 14th November is a special day for us. It is World Diabetes Day. And we thank Dr. Om Gardner once again for his expertise and his experience, the time that he shared with us. We also thank Team FDC for being with us every day. They are with us 24/7. And every week, 1/7 on Sunday at 9 p.m., we meet you for Diabetes Essentials. These days, we are talking about iron. But once our iron talks are over, we'll come back to diabetes and feel free to share whatever topics you want discussed. Once again, thank you all for being with us on this special day. I'd like to hand over to Mr. Anang Basu, but I have a question, Mr. Basu, for you.
Yes, sir.
What is it which motivates you? What is it that keeps you going in the field of diabetes, though there is no commercial interest?
It's very simple, sir. Today, on the World Diabetes Day, even the World Diabetes Forum also, IDF also has made this theme of this year is that educate not only the providers of the diabetic care, but also those people who are seeking the diabetes care from the doctors like you. So, when 1 out of 2 people don't know how to get treated and what to, how to spend the rest of the life with the diabetes. So that's the basic motivation. I feel personally, forget about any organization. I personally believe in this, that India with 10 crore population, if the providers as well as the seekers need to be educated, need to be aware how to manage the rest of the life along with the diabetes. We need to carry on with you, because as we saw it today also, that we can get the global experts for 1 hour, 1 hour, 20 minutes and share their views, what's happening in the world of diabetes and how the strategies of glucose-lowering drugs or the lipid-lowering drugs are moving towards which direction. But ultimately, doctors like Sanjay Kalra, who are the head of the knowledge providers and the service providers to the diabetes care population in India, needs to continue this journey. And that's why, sir, we want you every Sunday 9 p.m. with our Diabetes Essential with Sanjay Kalra at 9 a.m. Today, we know that because of our special efforts from your end, efforts from all the physicians and endocrinology societies, we could gather a lot of doctors today. But ultimately, we need to get them real platform at night and share their problems, their resistances and their experiences, and get a guideline from doctors like Sanjay Kalra. That is why, sir, we are here every time.
Actually, the motivation, sir, we get from each other. Like now, Dr. Gauri Shankar is with us from Karnataka. So he points out that there is actually no specific contraindication for statin usage. Of course, if the patient is not able to tolerate, let us say the patient develops myopathy or myositis, but that will be very rare, not even in 1% of your patients, then you will stop. Should we give statins compulsorily to everyone above 40? That is a question mark. But everyone with diabetes above the age of 40, certainly we should be prescribing because it reduces CV risk. In women also, postmenopausal women, because they're at high risk of CV disease, there's no harm in starting a statin. So do discuss with your patient. Each patient is different. And if you're confused, you do the Q risk 3, capital Q, capital R, ISK 3. Just put in your patient's data in front of him or her in the OPD and just see what is the risk of ASCVD in the next 10 years. This is assuming that patient does not have established ASCVD. If patient has established ASCVD, then it is clear cut. You have to give aspirin, you have to give statin. But if patient doesn't have ASCVD, we want to find out the risk. Q risk 3 will tell you, and then the patient will immediately be able to decide on his or her own whether they want to take the statin or not. So thank you, Dr. Gauri Shankar, for that last question. And once again, Mr. Basu, thank you very much for being with us. And
pleasure.
To everyone,
it's always pleasure with you, sir. We look forward to getting more people again back with us on every Sunday with Dr. Sanjay Kalra and carry on this journey. Thank you very much, sir.